Good afternoon, good evening, wherever you are in the world, welcome. We hope you're safe and well, and we look forward to a COVID-free and really interesting meeting that KDIGO have hosted for us. My name is Rukshana Shroff. I'm a pediatric nephrologist at Great Ormond Street Hospital in London, and here are my disclosures. So the CKD-MBD guideline, is it outdated or updated? Let's look at this. So in 2009, KDIGO had the first controversies conference and guideline development group, and this term CKD-MBD was developed. 6 years on, in 2015, a controversies conference was held in Madrid, where we discussed the guideline and considered whether or not it needed updating. It was agreed that a selective update would be performed. A detailed literature review took place, and the literature was reviewed up until 2016. Thereafter, in 2017, the guideline was developed, and I hope many of you have had a chance to see it. So now we are 6 years on from the last literature review. And where are we today? Do we need to move on, and do we need to update this? Just as a quick snapshot, you see the original guideline here, and the different colors tell you what has been updated. So you can see some sections have been updated quite substantially. You see that the gray areas are minor adaptations, and then about a third of the guideline in the white unshaded area is left unchanged. In that 2017 guideline, Professor Markus Ketteler co-led the group, and Marc, Vervloet, and I had the privilege of being on this committee as well. So today it gives me enormous pleasure that the three of us can come together to present this to you and to discuss a guideline update. The objectives of our webinar are to review the recent literature on calcium phosphate and PTH management, to look for new data that supports or refutes the existing guidelines, and to consider whether we need a change in our practice. You will see that there's a poll available here through Slido with this event code. Please do go to that poll and do give us some feedback and answers there. It'll help us make this an interactive session. Also, you will see that there's an option to post your questions, and we look forward to these so that they can be discussed at the end of the webinar. So now, without further ado, let me introduce Professor Markus Ketteler, who's going to discuss PTH management and vitamin D therapy, breakthroughs or steady state. Markus is a professor of nephrology in Stuttgart, Germany. He's done extensive research in CKD-MBD, including vitamin D and calciphylaxis, and is just the man for this talk. Following on from his talk, Professor Marc Vervloet from Amsterdam in the Netherlands will talk to us about the control of phosphate and calcium in CKD and what are the implications of novel studies for the KDIGO guideline. Marc is an authority in this field as well, has done extensive lab and clinical research in vitamin D and calcium phosphate management, and we look forward to the talks. So let me hand over now, and we go straight into our talks and look forward to your questions. And once again, the Slido, do complete the poll on that, please. Thank you.
Thank you, Rukshana, for your introductory words. I'm very glad that KDIGO gave us the opportunity to look a little bit beyond the last CKD-MBD guideline update. And my part now will address PTH management and vitamin D. I called it breakthroughs or steady state, left a question mark, and try to give some answers in the end. My disclosures, I received lecture and consulting fees from Amgen and Vifor Pharma in the past. My chapter is chapter 4.2, treatment of abnormal PTH levels in CKD-MBD. And there are two pre-dialysis or not on dialysis guidelines that were updated in 2017. The first one is kind of my favorite guideline. The optimal PTH level is not known. It's a typical guideline statement or a bit of a funny one, but it's true. And this is important about the handling of how to address secondary hyperparathyroidism in this group of patients. It stays as a given that hyperphosphatemia, hypocalcemia, high phosphate intake, and vitamin D deficiency should be in focus here when judging and consulting people and patients in these stages of disease. There's no big change. And one of the most controversial update guidelines was this new 4.2.2, where we switched from recommending or at least suggesting treatment with calcitriol or vitamin D analogs to a kind of a warning that these agents should not be routinely used and to be reserved for patients in advanced stages of CKD 4 to 5 with severe and progressive hyperparathyroidism. The background were two studies, Primo and Opera at that time, where it was shown that with these treatments, there was no clear cardiovascular benefit, but a relatively high risk for hypercalcemic episodes to occur, and also for aggravating hyperphosphatemia. So where are we now in these non-dialysis CKD stages? We have some treatment options, but they are supposed to be a little bit suboptimal. First of all, in the first line here, we have the native vitamin D, the cholecalciferol or ergocalciferol. And this, when given, elevates the 25-OHD levels, usually leaves calcium and phosphate undisturbed. But the effect until now in studies on PTH is rather moderate, if at all, and it has no action on FGF23. In some European countries, an immediate release calcifediol 25-OHD compound is available, which has similar action levels on the patient side, does not give more potent effects usually than the native vitamin D. On the other hand, calcitriol, pericalcitol are very much able to lower the PTH levels quite efficiently, but as a side effect, they increase calcium and phosphate levels. They indirectly, by feedback mechanisms, even lower the 25-OHD levels, and they increase the FGF23 levels, which has been shown now in a good number of studies. The ideal compound would be one that probably leads to increases in 25-OHD levels, but still lowers PTH levels quite efficiently without having impact on calcium and phosphate levels. And there indeed, we have a substance that might serve these purposes, which is ERC or extended release calcifediol. In Europe, it will be referred as a prolonged release calcifediol. And due to a waxy capsule formulation, it is only very slowly absorbed in the gut. And the key study is reported here, the pivotal trial, which compared in two arms, a placebo-controlled trial with two different doses of ERC, 30 and 60 micrograms per day in roughly 300 patients, following an endpoint study after 26 weeks into an open label extension study for safety and efficacy issues. The key effects of this trial, including the open label episode, was that the plasma IPTH levels dropped down quite significantly after half a year in a titration mode. And in the open label extension, the placebo patients were also put on ERC, and they followed the path with a protracted lowering of the IPTH levels in plasma. So there was a sustainable effect in this population. In parallel, the 25-OHD levels rose absolutely accordingly to the PTH effect in both phases of the trial. And what is probably important to note here is that 25 OHD levels of above 50, sorry, were absolutely necessary in order to get a profound effect on IPTH lowering. And this may be some clue to the future treatment of secondary hyperparathyroidism in non-dialysis CKD patients. At the same time, the effects of on serum calcium and serum phosphate, here depicted in the two graphs, were kind of negligible. This side effect could be excluded by this slow release, prolonged release formulation. And so this substance seems to be superior to the active compounds. And the key reason here could be that by this slow release of the compound, the catabolic feedback mechanisms via activation of 24 and 25 hydroxylases is not coming into play. And therefore, the hydroxylation of calcitriol by this prodrug is so efficient that the PTH effects are very sustained. And here you see the participants of the study put into quintiles according to their 25 OHD levels. And with rising OHD levels in the blood, the effect on PTH lowering was always highest in the fifth, in the highest quintile, while levels above 90 microgram per liter or nanogram per milliliter were not more efficient to lower the PTH. So the range of 50 to 90 is where we probably have to track in the future. Another important, or in this concept, important observational trial was very recently published by the DOPS registry. And this looked at the SHPT control in incident dialysis patients. So what was achieved in non-dialysis patients with secondary hyperparathyroidism, how did that translate into the first year when patients started dialysis? Here, a total of 2,728 patients eligible for the PTH outcome analysis were investigated all over the world in the contributing centers. And you can see here that the regional or national distribution of different PTH levels in this observational trial. And usually more than 50% of the patients were in at least below 300 picogram per milliliter with their PTH levels. This is the yellow column. And depending on the country, those above or far above were limited or even more prominent in some of the countries. The follow-up control, on the other hand, shows that even patients with starting IPTH of above 600 picogram per ml, only less than 30% remained in this high range 9 to 12 months after hemodialysis start. There was a substantial number of patients who could be treated into better PTH levels. And so the impact this may have, more targeted PTH control during non-dialysis CKD may influence outcomes during hemodialysis and potentially reduce the requirement for PTH lowering medication. And this can help to inform improved clinical management for non-dialysis CKD. And so if we have the right drugs to approach this, they should probably get used. The second part of this is the maintaining or lowering of PTH levels in patients on dialysis. Here, the new guidelines 2017 were quite identical to those in 2009, only changing the order of the compounds that come into play based on their alphabetical order, but not defining any first-line substance. Here, one also observational trial looked at the impact of mineral and bone parameters on outcomes of these patients. And in the part that Marc Vervloet presented to you, where it was recommended that the clinical management of CKD patients or of CKD-MBD should always look at the three major players, which are calcium, phosphate, and PTH. This study put this notion up and looked at PTH, calcium, and phosphate according to the previous guidelines, defining kind of the target range, low and high levels, resulting on the right side into 27 phenotypes from low, low, low over target, target, target to high, high, high. And essentially, the results were that a number of phenotypes were associated with quite a low mortality risk. And I would like to point out the highest, the 1.0, the reference level, which was actually really found in the target range. And I think personally that this is very supportive, that the guidelines and the update are currently in a good shape, because it would have been a bit disastrous if the target would not lead the survival benefit, but it does. What defined the worst outcomes were essentially 2 points. On the right side, the patients with high phosphate levels in this cohort. Hyperphosphatemia was always associated with worse outcomes. But quite interestingly, here, an over-suppression of PTH levels in these prevalent 36,000 dialysis patients was an equally strong predictor of mortality. And that means that in the prevalent dialysis state, that we should not overreact to lowering PTH, at least in Western populations. The situation in Japan may be a little bit different. But here we have a clear signal from an observational trial that we should not oversuppress. A new compound that came out on the market in at about the time when the new guidelines were worked out and published was ethyl-calcitide as a new parenteral calcimimetic. The guidelines stated calcimimetics, so that compound was already thoughtfully included. And there were a few studies now on working with the substance under real-life conditions. And one thing, or one thought about the usefulness of ethyl-calcitide was the parenteral mode of administration, because this secured the drug to reach its target. And the second problem with Cinacalcet was that a good percentage of patients were not well tolerating the substance concerning gastrointestinal side effects. And so this example study looked at patients who were probably adherent or non-adherent to the substance. And the study started with a washout period, and you can see here on the left side that the adherent patients, even within 1 week, quite significantly rose with their PTH levels. And indeed, the non or less adherent patients did not fully rise with PTH levels in this washout phase. So one thing that indeed pointed out that the adherence of the patients could play a part here. The percent change in PTH levels is shown in the graph on the right side. Independent of previous adherence or non-adherence, PTH could be quite effectively lowered with ethyl calcitide in both groups, showing that there was not a point of sina-calcet resistance, but or calcium mimetic resistance. This worked out equally well, and this study demonstrates that we have a new substance that might have at least the superiority of making sure that the drug reaches its target. One more point that was not renewed or updated in 2017 was the reference to the baseline or the native vitamin D levels. It was left because there were no new studies, and there was no evidence speaking against the approach that vitamin D deficiency and insufficiency should be corrected using treatment strategies that are recommended for the general population. On this ground, a large trial, or the so far largest trial, was published. Meanwhile, in 2018-19, the VITAL trial, which included healthy people with into two arms that were partly shared, with vitamin D3 in a dose of 2,000 units per day, and also an arm that included omega-3 fatty acids at a dose of 1 gram per day compared to placebo. And these patients were observed for approximately 5 years, and it was looked at the pleiotropic endpoints of cancer and de novo cardiovascular disease. As I said, nearly 26,000 patients were included into the primary analysis, and disappointingly, one would say on the first glance, there was no significant effect on preventing invasive cancer of any type or preventing major cardiovascular events. There was a secondary endpoint, the tumor progression of patients who already had cancers was slower in vitamin D treated patients, but that was one of the few positive results here. The problem of the study was possibly that these patients at baseline were not in a vitamin D deficient state. In those patients where vitamin D levels were measured at baseline, the levels were nearly 30 microgram per liter or nanogram per milliliter, and they were only rising up to 44 microgram per liter or nanogram per milliliter after 5 to 6 years of follow-up. And so the target population was possibly relatively healthy. So this kind of excess vitamin D did not show a biological effect. As a subgroup here, De Boer and colleagues were able to investigate the effect of vitamin D on kidney function in those patients included with type 2 diabetes. This came up to a population of 1,300 patients here. So still a relatively large population, which was looked at under different conditions. And the endpoints that were looked at were changes in GFR estimated from creatinine and cystatin C from baseline to year 5, and also to look at the development of albuminuria or microalbuminuria. It has to be stated here that the initial GFR was 85 mils per minute. So overall, this cohort was not already in a progressed state of diabetic nephropathy. This was how it was done. So it could be grouped into 3 arms: pure vitamin D treatment, pure omega-3 fatty acids treatment, combined group, and 2 placebos. And it was looked at a baseline year 2 and year 5. And according to the results of the overall trial, also in this subgroup, the vitamin D did not lead to amelioration, improvement in the loss of GFR over the time course that was observed. And it also did not have an impact on albuminuria development over the time course observed. But as I said, the group was more or less on average vitamin D sufficient, and therefore a study should be designed or should look at the approach of correcting vitamin D deficiency into normal ranges. My final slide. My question was, were there breakthroughs? I would say no real breakthroughs, but some progress in some areas of CKD-MBD according to SHBT management and vitamin D. In overall, the recent data are more supporting than challenging the KDIGO CKD-MBD Guideline update of 2017. We may have possibly new targets for vitamin D status in ND-CKD patients, but most of the studies lack hard endpoints. There is further evidence for risk associations with adynamic bone low PTH status in dialysis patients. There are still no additional randomized control trials targeting hard outcomes in this area beyond the EVOLVE trial, which I think is now 8 or 9 years after publication. And on a personal note, subjective note, no substantial novel evidence currently would justify current guideline revision update, as further clinical data are needed. With this, I close my presentation. Thank you very much for your attention, and would be looking forward to any questions. Thank you very much.
Thank you, Rukshana, for the kind introduction, and thank you, Markus, for your nice overview of what has been studied on vitamin D and PTH. And now I will carry on with control of phosphate and calcium in chronic kidney disease. And the focus will be on phosphate, and I will tell you in a minute why. But first, as Markus did, I will give a short outline of what the 2017 guidelines of KDIGO told about phosphate and calcium control. These are my disclosures. Treatment of CKD-MBD should be based on serial assessment of phosphate, calcium, and PTA levels considered together. In addition, we suggest lowering elevated phosphate levels towards the normal range, and this is a slight change from the old guideline, where it was suggested, and you see the old guideline in gray on the lower part of the slide. At that time, it was suggested to also maintain serum phosphate levels in the normal range. So the difference is that in the past, we suggested to maintain it normal, but now the focus is more on lowering elevated phosphate. The reason for this is that there is an absence of data that show that maintaining phosphate in the normal range is actually a benefit for patients. In effect, there may be some safety concerns while attempting to maintain phosphate in the normal range. So treatment should aim at overt hyperphosphatemia. And the new guideline 4.1.5 stated that decisions about phosphate lowering treatment should be based on progressively and persistently elevated phosphate levels. And I will come back to in a minute to this when I present to you novel data. In guideline 4.1.6, we emphasized that it's now suggested to restrict the dose of calcium-containing phosphate binders. And this is a slight difference from the past guideline, where there was a qualifier for which patients this calcium-containing binder should be limited. And we have now data that suggested, at least we had data in 2017, the time of the release of the guideline, that suggested that an overall restriction of calcium-based phosphate binders might be more important. And this is the rationale I just mentioned to you. And the final guideline I want to bring back to your attention, to bring back in your memory, was 4.1.8. And this was about dietary intervention. We already knew that limiting the dietary phosphate may be worthwhile, but we now added the sentence in green, the lower sentence in green, that it's reasonable to also consider the source of phosphate. So now we come to the core part of this presentation. So the 2017 guidelines are 4 years old today, and what happened since then. And I will focus on phosphate. But before I show you the new studies since that time, I want to make this additional disclosure. These slides did not undergo formal KDIGO review and are the opinion of one working group member, which is me. And I selected mainly clinical trials since 2017. So first, I want to show you new epidemiological data which underpin the rationale to treat hyperphosphatemia. And this was a study from Dobbs. The rationale to treat hyperphosphatemia has always been based on observational data only. And in the last few years, we have novel observational data which underpin this rationale. Now we have a novel analysis of the Dobbs database. And in this analysis, a different approach was applied. So patients' phosphate exposure was the determinant and mortality was the outcome. And what they did was that for individual patients, the area under the phosphate curve was the determinant. So you see 3 examples here. The blue area indicates the phosphate exposure over 4.5 milligrams per deciliter. So the patient in blue has quite a high exposure to hyperphosphatemia. The orange patient has a much lower exposure to phosphate above the 4.5 thresholds. And finally, we have a patient indicated in red, in which phosphate is during the entire period of 6 months in the quite normal range. This patient has an area under curve of 0. If you categorize patients based on these outcome parameters, you see that there is a quite important association between phosphate exposure and 4-point MACE in congestive heart failure, cardiovascular death, all-cause mortality, and non-cardiovascular death. And you can see, especially for the cardiovascular endpoints, that exposure to hyperphosphatemia is an important determinant. So the conclusion of this Dobbs study was that phosphorus area under the curve, so phosphate exposure, is a better predictor of cardiovascular death than the single most recent phosphorus level. And this supports real-world data to the KDIGO recommendation that serial assessments are needed to guide clinical decision-making. Importantly, this still doesn't reach the highest level of evidence, but the evidence is ever expanding, so the rationale to treat hyperphosphatemia is increasing. So the next part I want to address is phosphate lowering strategies in the absence of overt hyperphosphatemia. And you remember I just told you that the KDIGO guideline suggested not to treat phosphate if it's not elevated. And we have 2 important trials and also a short-term trial on ferric citrate. The 2 trials I want to address are the combined trial and the improve CKD trial. The combined trial tested the hypothesis that phosphate binding in clinical care may be offset by higher active transport of phosphate in the gastrointestinal tract. And therefore, simultaneous control of phosphate by combining two compounds, and I will show you which compounds these are, may be beneficial in terms of phosphate control and in lowering FGF23. The patients were CKD patients, stage 3B and 4, and the follow-up time was 12 months. 205 patients were randomized to either nicotinamide with lanthanum, nicotinamide with placebo, placebo, lanthanum, or double placebo, and the endpoints, as I mentioned, were phosphate balance and FGF23. The baseline characteristics are demonstrated here. Patients were 69 to 70 years old. The eGFR was around 32 to 33 milliliters per minute. Phosphate was in the normal range, so the average phosphate was 3.6, 3.8, and the phosphate excretion in 24 hours was about 650 to 700 milligrams per day, which is quite reasonable. And here are the results. So the serum phosphate concentration was not influenced at all in any of the allocation arms and did not differ from placebo. So PP indicates the gray line, double placebo group, no difference. FGF23, so if there is no change in phosphate concentration, the question was, would FGF23 decline due to this double intervention? But the answer is no effect at all. And then the final finding was that in the two allocation groups which contained lanthanum, there was a decline in 24-hour phosphate excretion. And you see here phosphate over creatinine ratio, indicating that those allocated to lanthanum indeed appear to have a lower uptake of phosphate, but there was no effect of the group that was treated with nicotinamide in isolation. The second trial, looking at the rationale to treat higher phosphate concentrations in the absence of hyperphosphatemia, was the IMPROVE CKD trial. And the hypothesis was that phosphate load, different from phosphate concentration, induced a decline in FGF23, and this might be a mediator of improved cardiovascular endpoints. Like the combined trial, this was in CKD stages 3B and 4, and the follow-up time was almost 2 years. Patients were allocated to lanthanum 3 times a day, 500 milligrams, or placebo, and the number recruited was 278. The primary endpoint was carotid femoral pulse wave velocity, abdominal calcification, and biochemical endpoints. Patients were quite comparable to the previous trial I just showed you, the combined trial. The age was slightly over 60. Creatinine level was 220, estimated GFR 27, 26, and phosphate was in the normal range. C-terminal FGF23 was slightly elevated with 221. And here are the biochemical endpoints. So there was no effect of lanthanum compared to placebo in concentration for phosphate. There was no statistically significant effect on phosphate excretion. Lanthanum indicated in blue, which is the upper right panel here. No effect on parathyroid hormone and no effect at all on C-terminal FGF23. The primary endpoint of this study was change in pulse wave velocity, but again, there was no effect at all of lanthanum carbonate over placebo, and placebo is indicated in red. And please note that the lower pulse wave velocity is a better pulse wave velocity. So the interim conclusion on phosphate binding therapy in the absence of overt hyperphosphatemia is that these trials demonstrate lack of efficacy for any phosphate binder to lower phosphate if it's normal at baseline. And this actually reinforces the 2017 KDIGO guideline. So what about goals of treatment? Because as you remember, the guideline stated or suggested that we might want to aim to normal range. And the first question is this feasible to start with? And the second question is, will this be beneficial if we aim for normality? And two studies addressed these two questions, and these were the target trial and the episode trial. The target trial studied question number 1, is it feasible to attain different phosphate targets? And the study did so on prevalent patients on dialysis. It was an open-label trial for half a year. And patients were treated with calcium carbonate as monotherapy and allocated to a phosphate goal within the normal range, the blue bar, or to a more liberal phosphate goal to 2 to 2.5 millimolars per liter. And the endpoint was phosphate concentration and binder dose. And since this was in calcium carbonate phosphate binder therapy only, it is important to note that total elemental calcium allowed was kept at 3 grams for all. These are baseline characteristics. These were all patients on dialysis. Serum phosphate concentration at baseline was elevated for both groups, more or less at the upper margin of the targets of the old KDIGO guideline. And this is the important baseline characteristic, I would say. Not surprisingly, the number of phosphate binders used was quite a bit higher in the intensive group, which is the red line you can see here. And actually quite a few patients who were on the liberal phosphate goal didn't need any phosphate binder at all. So there were quite a few patients on the 0. And this was the main endpoint of the study, which was the difference and the divergent effect on phosphate concentration. And you can see that it's quite feasible to achieve quite intense phosphate control in the red bar, in the red line. And there was no important effect on calcium concentration. So there is a slight increase in serum calcium concentration, which is not very surprising given the fact that calcium carbonate was the compound used to attain this phosphate control. And then the episode trial. This is a very recent trial from Osaka, from Japan, published in JASN quite recently. And this study did not look at the biochemical endpoint of phosphate control, but looked at an intermediate endpoint, which was coronary artery calcification after 1 year of treatment. This was a 2-factorial study design, and patients were randomized to 4 groups: lanthanum-based treatment with either an intensive phosphate control or standard phosphate control, or sucroferric oxyhydroxide treatment based with either an intensive phosphate control or standard phosphate control. And I already mentioned the endpoints, which you see on the right-hand side. These were prevalent patients on hemodialysis, and here you see the baseline characteristics for factor 1, which was the difference between type of phosphate binder use, lanthanum carbonate or sucroferric oxyhydroxide, and factor 2, which was standard control or strict control. Importantly, there were no major baseline characteristics for coronary artery calcification, nor for phosphate concentration. Importantly, or possibly importantly, I want to draw your attention to the ferritin levels. Ferritin above 300 nanograms per milliliter was an exclusion criterion. So this is a more or less characteristic feature of a Japanese group of patients on dialysis with quite low ferritin levels compared to Western countries. And here you see the results. In the upper panel, so panel A, you see the difference in two types of phosphate binders on phosphate control, and the bottom line of which is that there is no difference in phosphate control for patients treated with lanthanum or sucroferric oxyhydroxide. The bars on the top panel indicates the total amount of milligrams per binder, and this indicates that the dose needed of sucroferric oxyhydroxide was a bit lower compared to lanthanum carbonate. Arguably more interesting is the panel on the lower end, and here you see phosphate control. And you can see here that again it was feasible to induce a difference in phosphate control. And here you see the primary endpoint. And the primary endpoint is the effect on change in coronary artery calcification. And what you see here is that the lower phosphate concentration is, or the more it declined over time, the lower is the progression of coronary artery calcification indicated on the left-hand side. No difference for lanthanum carbonate or sucroferric oxyhydroxide. And what you see here on the right-hand side is that the same holds true for the standard treatment goals compared to the strict treatment goals. And obviously for those on a strict phosphate goal, the line is below the line with the more liberal phosphate levels. And here you see the effects categorical. On the right-hand side, you see the primary endpoint where the standard phosphate control is compared to the strict phosphate control. The primary endpoint was the percentage change of coronary artery calcification. So the interim conclusions with regard to phosphate targets are that uptitrating phosphate binder dose is feasible. And this is accompanied by a phosphate concentration close to normal, also attainable for patients on hemodialysis. Intermediate endpoint, coronary artery calcification, using non-calcium-based binders demonstrates that on this endpoint, this appears to be beneficial. But we still lack a trial with a hard clinical endpoint. But this study does reinforce the KDIGO 2017 guideline that suggested that we should aim at normal phosphate levels. So what about new strategies to target hyperphosphatemia, or should we continue with what we have? And I will show you one slide on a recent meta-analysis of dietary interventions to target phosphate in patients on dialysis. I will show you the landmark trial, and I'll have one slide on nicotinamide and the amplified trial using tenapanor. This is a very recent meta-analysis of a quite variety of dietary interventions used in patients on dialysis, and these are all randomized trials. But you can appreciate from the red circles that overall there was an beneficial effects of the intervention by dietitians, and overall there was a 0.8 milligram per deciliter decline in serum phosphate concentration for patients who had this dietary intervention, which was on top of phosphate binder therapy in most of these studies. So the landmark trial is currently in press. This was a study from Japan in prevalent patients on hemodialysis. These patients were selected to be at higher risk for cardiovascular disease, and our colleagues from Japan did so because the endpoint was cardiovascular mortality and cardiovascular events. And all patients had the same treatment goal, phosphate concentration of 3.5 to 6.0 milligrams per deciliter. This was a large trial, and patients were randomized to calcium carbonate or lanthanum. The baseline characteristics of this study have been published a few years ago, and you can see that the majority were male. The age was 68. 68. Body mass index was 56, which is quite average in Japan, I guess. And the dose of lanthanum at baseline use was 1 gram per day, and calcium carbonate was 2.3 grams at start. And here you see the phosphate concentrations at baseline. As I mentioned, the study is in press, but the results have been published at the ASN in 2018. And the bottom line of the results is that there is no difference in patients treated with lanthanum carbonate or calcium carbonate. And like many of you, I'm eager to see the full publication. So what about new compounds? And it's important to stress that new compounds have been studied on biochemical endpoints only. A recent study combines the effects of sevelamer and sucroferric oxyhydroxide on biochemical endpoints, and the effects were combined or pooled because the effects were the same for these two binders. And after 1 year of treatment, both phosphate binders induce substantial phosphate declines indicated in panel A, and importantly, there was also a substantial decline in FGF23 for the two phosphate binders, as you can see in panel B. An important difference between the two binders was that for sucroferric oxyhydroxide, the pill burden was much lower compared to sevelamer. And the final compound I want to mention is tenapanor. Several studies already demonstrated when tenapanor is used as monotherapy, there is an improvement of phosphate control compared to placebo. And I think the Amplify study better reflects real life, because here tenapanor was used on top of baseline phosphate binder therapy in patients who were not very well controlled. So at baseline, these patients had uncontrolled hyperphosphatemia. The gray line indicates phosphate levels in the short-term trial for patients who continued their baseline phosphate binder therapy. And when tenapanor was added to this therapy, the results are reflected by the black line. So there is a substantial decline of phosphate level when tenapanor was added to baseline phosphate binder therapy. So when selecting phosphate lowering strategies, the conclusions are that there is confirmation of the role of dietary interventions. We might need to revisit the role of calcium-based binders based on the landmark trial, but we still need to be cautious for two reasons. The full publication is not out yet, and the external validity might be something to discuss. We'll see. Novel compounds have some effect on phosphate control, but these studies will not impact the KDIGO guideline because they only have biochemical endpoints. So my overall conclusions with regard to phosphate control in chronic kidney disease are that there is a rationale to treat hyperphosphatemia, which is still based on observational data, but this database is more solid now. Next, more data substantiate the suggestion not to use phosphate-lowering compounds in the absence of overt hyperphosphatemia. The next conclusion is that aiming at normal phosphate range for phosphate control in patients on dialysis is feasible and actually may retard vascular calcification, at least so for the coronary artery system, and at least so when calcium-free binders are used. In selected populations, and I showed you the Japanese landmark trial, calcium-based binders may be as good as non-calcium-based binders. And my final conclusion is that novel phosphate-lowering agents have been studied, are efficacious on phosphate control, but have not been studied on more important endpoints yet. And that's it. I now hand over to Rukshana to lead our discussion, and I'm happy to take a few questions.
Thank you very much, Marc and Markus, for this excellent talk. This has been excellent and a very, very good overview. On the whole, I'm absolutely delighted to see that that the guidelines we produced in 2017 are in fact reinforced by the recent literature rather than contradicted. And perhaps some of our guideline statements may even have a stronger grade associated with it, given more recent results. We have a number of questions that have come through which are really exciting. Perhaps I can start with a question for you, Markus, if that's okay. The question says, is there any update on PTH assays and the validation of these assays?
No update on this, but it seems very clear that the BioIntact whole PTH assays are comparable with their reliability, specificity, and sensitivity with the IPTH assays. And the discussion about the oxidized PTH is currently at a stage where it does not seem to influence or impact on the interpretation of the results very much. If there is something coming up, we need to re-report, but in the last 3 years, there was nothing that reinforces another view.
That's right. Thank you. Just, Markus, I'm going to ask you a few questions first because I know you need to leave soon. So
Right.
yes, I know. So very quickly, in dialysis patients, do you suggest a target for vitamin D levels?
For 25 OHD levels, no, I'd just say it's an interesting question now with the results of the ERC, where it seems that levels of 50 to 80 or even 90 might be effective to control the PTH. But I think concerning the pleiotropic effects, the remainder of the effects, it's still unclear. And it is unclear whether the ERC formulation, the pharmacodynamics and pharmacokinetics determine this response on PTH, so there is still some work to be done. And there is a study around that tries to address that.
Excellent. Do you have 1 more minute for us, quickly?
One more.
FGF23 levels, were the FGF23 levels measured in the vitamin D studies that you presented?
Yes, I think they were measured and they were unchanged.
That's very interesting. Thank you so much. Markus, I know you need to go, but thank you for your time and a superb talk. So perhaps...
Thank you so much. Thank you. Bye-bye.
Thank you again. Bye-bye. So don't go away, everyone else, because Marc is now up in the hot seat and we have lots of really good questions that have come through for Marc as well. So Marc, first question, with phosphate binders, do they change the intestinal microbiota? And is that something that we need to be concerned about?
Well, I assume they do change the intestinal microbiota. And I agree that one might assume that this is of importance, but this is something that needs to be studied. And actually some of the unexplained differences between phosphate binders might in fact be mediated by this effect. I don't have the answer, but it's an intriguing position.
It is indeed, and there's some data on sevelamer probably from observational studies, isn't it? But a lot more work needs to be done on that, absolutely. So, Marc, another really good question that has come through. What about a reduction in urinary phosphate levels that have been shown, for example, in the IMPROVE CKD trial? Does that not matter? Should it matter?
Well, it likely implies that the gastrointestinal uptake of phosphate has declined. And this might indeed indicate there is a lower burden of phosphate load, but not so much of phosphate concentration. And in the discussion, if phosphate concentration or load is the culprit for cardiovascular disease, this argues for phosphate concentration, I would say.
Exactly. Absolutely right. Absolutely. And What about the fluctuations, the diurnal fluctuations in phosphate levels? We've seen some very interesting observational data on that. Can guidelines really accommodate for that, and do they look into that?
Well, so far the guidelines didn't look into that, but you're right, or the question is correct, that there is diurnal variation. Usually, especially in dialysis wards, it's very difficult to do a fasted phosphate drawing because patients come in the afternoon or in the evening. But my best advice is to make the drawing at the same time on the more or less the same conditions. But ideally, phosphate is drawn after a period of fasting.
Absolutely. Yes, exactly. And perhaps maybe a last question now. Many of the binders show an equivalent binding of phosphate and an equivalent serum, not binding, but an equivalent serum phosphate level. Looking at side effect profile then, because that is perhaps what makes our patients decide which binder they're actually going to take or not. Could you comment on that, please?
This is a very important question. I completely agree. So the best binder is, I think this is a wording from Jürgen Vleuke, the best binder is the binder the patient takes.
Exactly.
This has got a lot to do with tolerability, side effects, and so on. So I think you should select the binder which is most fit to the individual patient.
Indeed, absolutely right. So I think we're just over time, so perhaps it's now my chance to thank you, Marc and Markus, for fantastic talks, and to our audience for really interesting questions, for completing the poll. Most of you, we fully agree with your answers. Really, and we are very, very glad to see that our 2017 recommendations are in fact still valid and still hold. Pretty much possibly with more emphasis than they did before. So thank you everyone for attending the KDIGO webinar. There will be, we look forward to more feedback from you, and there will be many more webinars coming through from KDIGO. Thank you for your interest and your attention. Bye everyone. Thank you.
Bye.
Bye-bye. Thank you.